Hello everyone, this is Shad Reyes from SIF 2021. With me is Dr. Ashish Prashant. He is the Interventional Cardiology Director at Chandler Regional Medical Center. Ashish, always a pleasure to be here.
Thank you. My pleasure to catch up with you.
Yeah, absolutely. It's nice to have you again back. Nice to see the live cases and the illustration and learn from your skill set as a CTO operator. So tell us about the changes during COVID in practice, from slowing down procedures and now hopefully we're coming back up as the vaccine is there and the patient feeling more safe to come to the lab.
Yeah, I think this has all been an unbelievably unprecedented time for all of us. And, when it comes to elective PCI, yes. CTO, of course, being the ultimate example of an elective PCI, we had a big slowdown during the COVID, and rightfully so. Our hospitals were full, and the ICUs needed bed capacity, and hospital beds were at a premium.
Absolutely.
And so,
especially for CTO.
And we were when I was asked, how would I feel slowing down my CTO volume to accommodate that? How can you not? You're a human being and a cardiologist and a physician before you're an interventionalist.
That's what you do every day.
You do what you do to help everybody. And so I said, you know what, I'll be happy to put a hold on CTOs. But what ends up happening then is you develop a big backlist.
Yes.
And so I think we're at a point where we're now clearing out our backlog of cases, and I was in between jobs as well. So during the fall and the winter, the list kept getting longer because I had no place to work while we were slowly coming back. And yes. So I start work next week, and we already have a long list of 30 patients that need to get done.
Absolutely.
And
wow.
So I think it's a reflection of the times,
yes.
But I think that, as you rightly pointed out, the vaccine and the people's I don't know if it's COVID fatigue, but in general, I think people have now realized that they feel more comfortable with the protocols that the hospital has in place, and
yes.
getting tested before getting admitted, being cordoned off in a hospital that's away from the COVID unit, spending 12 to 14 hours and being discharged either the same day or the next day, I think has reduced most risk of exposure to patients.
That's true. So you are a proctor as well. You go all over the country to teach people CTO.
Yeah.
And this is maybe affected due to COVID. Do you think that will be a slow kind of accommodation of these new techniques because of COVID? Because we noticed, like, for example, for science and trials, recruitment has been almost paused.
Yeah.
So is this the same applicable for clinical skills?
It's interesting, over this time frame, I've been going to New Mexico at the University Medical Center there. I've been there 4 times since November. And, the excitement and the desire to learn and get better has never been dampened. People are seeking new ways to learn. People are, with CTO Connect,
yeah.
with Zoom meetings, and virtual proctoring now is also a big deal. So we have Asahi sponsoring, and I think even, if you want to be accurate, maybe even Abbott and Boston Scientific have some form of a virtual proctoring.
You have to be creative to accommodate
so that you can get to people, because you all know that we need bigger reach.
Yes.
The need is still very much unmet.
Yeah.
And so the operators that need to be skilled to do this have to be exponentially increased in the next decade.
Absolutely.
As we're going to get old and retire, we still need people that are young in your age to take over. Right. So we have to transfer that knowledge to you all in the next decade. Otherwise, we're going to be failing.
As I said, there is a gap, would be a big gap, and slow down.
Yeah.
So going forward now, let's shift gear to the CTO world.
Yeah.
What is up and coming in the CTO world?
I think
that excites you.
Yeah, no, I think there's a couple of new CTO devices that, although it's hard to ever imagine a device making a difference because these have all been incremental advances, but
yes.
I think there's a couple of new exciting CTO devices that I've been involved in. I can't share the details of the device itself, but some newer anti-grade tools will be available soon. We're going into some early feasibility studies,
nice.
Hopefully in the US first, and then if that truly turns out to be something that works, then I have a feeling that it'll make it more applicable, because the more difficult things in CTO PCI involve dissection reentry or involve retrograde work, and if we can reduce the percentage of cases that we do using that, I think it'll become more translatable to people because people are comfortable with wires and technologies of that nature.
It's like the TAVR. They started with a bulkier TAVR, sheath size is big.
Yes.
And over different iterations, think of smaller, you can proctor people over, as you said, the Zoom meeting.
Yes, it's quite nice actually. I think that would be a good example of how from 24 French we've gone down to 14 French, and it's made a big difference. And similarly, if we can reduce retrograde and ADR, I think our adoption will improve tremendously.
Right. Despite the fact that there is mixed feelings about CTO or opening CTO,
yeah.
I think CTO is still here to exist, especially for angina relief and patient satisfaction, and leave them without pain from angina.
No, I agree. I mean, I don't think that none of us, even who are operators and do a lot of CTOs, believe that we're conclusively impacting mortality, because very little things that we do impact mortality other than left main intervention and proximal LAD. Everything else that we do, and STEMI, and shock, everything else that we do is essentially for quality of life improvement. Exactly. So without a doubt, I mean, you have patients on 2 anti-anginal agents that are crippled with angina, and we see them every day, all day. The question is, if they're not getting CTO PCI, and if they're not getting treatment, then are they just adapting their lives and slowly doing less and less and being miserable, or are we going to offer them a form of therapy? Because there's no tangible way to assess the patient's dissatisfaction, because he believes what is being told to him, and if the doctor tells him that there's nothing else that can be done, he has to take 10 pills a day and not play golf anymore, that's what he's going to do.
Yes, absolutely. Well, Dr. Pershad, thank you so much for your time.
Perfect.
Really a pleasure meeting you and
Likewise.
having you again in person. Please watch this video and others on SIF YouTube channel. This is Shadi Reyes from SIF 2021. Thank you so much.
Thank you so much.